Good afternoon, everybody. Thanks for joining us for today's webinar, where we will look at the impact of COVID-19 on neurosurgery and neuro-oncology in Europe. We're honored to have Dr. Carlos Velasquez from Spain in Santander, and Dr. Laura Lippa, who is a neurosurgeon in Livorno, Italy. And as I mentioned, we're trying to make this session as interactive as possible. So please, if you have any questions, just type it in the chat. But otherwise, we'll try to give an overview of the experience so far of neurosurgery in these two hot zones of COVID, and kind of try to get a comparison with the United States to see where we've come from, where things are looking at right now, and potentially where we'll be going. So with that, I'll ask Dr. Velasquez to kindly take it over with his presentation.
Okay, thank you, Dr. Mansour, for having me. It's great to participate in these kind of webinars, because I think they help others to understand the impact of this pandemic on neurosurgery, and to learn from it. So first, I will give just a few slides for a perspective of the impact of the pandemic, specifically on neuro-oncology here in Spain. I have no disclosures. This will be kind of the outline. First, we will talk a little bit about the initial impact. So when we were not prepared, for example, in the neurosurgical departments, then we will talk a little bit about the evolution of the neurosurgical care, especially in neuro-oncology, through the pandemic. Then the post-pandemic era, I mean, what lessons we have learned, and our future perspectives. And then just one slide on research in neuro-oncology during these difficult times. So first, the initial impact of COVID. So to put everything in perspective, this is the number of cases in Spain, and we started, the number of cases started to increase from middle of March, and then they have increased significantly. We have two main hotspots. One is Madrid and the other one is Barcelona, but we have a lot of cases in the north of Spain, especially in Basque Country, and we don't have as many in the south of Spain, in Andalusia. Right now, we have more than 200,000 cases with almost 27,000 deaths. So that's how big the pandemic is here. The other side of the other face of the coin is how we have improved over the last few weeks. This is the daily increase in cases, and how it has declined over the last weeks. We started with a big number of cases every day, and now we have reduced that to a minimum. We are still having cases, of course, but these are good news for us. So with this in mind, so this is what happened during the first week or 2 weeks in the neurosurgical departments in Spain. So all this data comes from a survey that was done by the Spanish Neurosurgical Society. This is the participants showing that it has a little bit of representation of each part of Spain. And when they ask the neurosurgeons here in Spain how much reduction in the neurosurgical activity they have experienced, the majority of them, almost 55%, said that the reduction was more than 80% in the neurosurgical activity of their departments. And this reduction happened mostly before March 20, more or less. So after March 20, this had already happened, the reduction. So we have been in this situation, you could say, from March 20 and after. So first, of course, we had to prioritize the cases. So almost 2/3 of departments or neurosurgeons were prioritizing neuro-oncology cases and emergencies, both. Emergencies, talking about, well, you know, the usual trauma, uh, SAH, and some pathologies like that. But 1/3 of neurosurgeons were prioritizing emergencies only. So probably they were excluding some neuro-oncology cases.
Would you have any idea what they were doing with the, you know, the category of neuro-oncology cases that are, you know, some of them are urgent?
Yeah, so there was not a question specifically to assess that. Anyway, there's a second survey that the Spanish Neurosurgical Society is doing right now, and we hope we will have more data from that survey. But yeah, that's an interesting question because, as you say, some neuro-oncology cases are really emergencies. So maybe in those cases, the participants of the survey consider those cases as emergencies, and they will fall in this category. But I mean, probably neuro-oncology cases for them, and this is not clear from the survey, maybe neuro-oncology cases is we're talking about brain tumors, but which do not represent an emergency at that moment. You have to keep in mind, I mean, I don't know in US, but I had the opportunity to compare with Canada. In Canada, when you admit a GDM, for example, you will try to do the surgery in the first 48 hours, 72 hours, if possible. I don't know if you agree with me. But then here, at least in Spain, in the majority of the neurosurgical departments, you could consider that case as an elective, for example, as instead of doing the case in the first 72 hours, you could do it, for example, the next week on Monday, for example, and you will an elective OR time, for example.
Wow. So that's a very good point to bring up when we'll get to the slide on our group's assessment of prioritization. So in our assessment, we'll get to it, as whoever has a progressive neurological deficit and at risk of imminent death, then we try to do the surgery immediately. But if it can be temporized, we try to do it on a semi-urgent basis, as you said. So kind of along the same lines.
Yeah. So, and then this is not from the survey, but this is from sharing experiences with my colleagues in Spain. What almost all the neurosurgical departments in Spain tried to do was to take these measures. First, social distancing among the members of the neurosurgical team, because you have to keep in mind that the majority of the departments here, we have maybe 10 neurosurgeons, probably. So if one got infected, so what you wanted to avoid was this first case, you know, that a member of the team got infected, COVID positive, and then all your team would get infected from that single case. So this what probably was worrying the head of the departments because they wanted to keep the staff safe, of course. But they wanted also to maintain the medical attention in neurosurgery, and you couldn't do that if all your staff is sick. So what the majority of the departments did was multiple teams, for example, to divide the department in 2-3 teams. It depends. I've talked to colleagues who work in a 4-member team, neurosurgical team. So they split into groups of 2, of course. So, but the thing is, this had a problem as well because you could lose one team, of course. So probably what they were trying to do in the middle of the pandemic, like 3 2 or 3 weeks after the first cases, was to have multiple teams and plus testing, because in that way, if you isolate one case in your team early, then you can quarantine that person, and then you will still have the rest of the team. For example, I was on call with a resident last week, and the resident saw an emergency case, well, a consult in the ER, and it turned out to be a positive case, the patient. So immediately, the head of the department told the resident to go home immediately, and I had to, of course, finish the on-call by myself. Of course, that's how strict they are trying to maintain these rules. Mm-hmm. Then, of course, after telemedicine, of course, OR protection. I think this has been emphasized a lot in the neurosurgical literature. And then, of course, we had to keep with non-COVID neurosurgical care. Like consults, urgent or emergent procedures, right, and what you were saying, prioritizing procedures. But
Dr. Velasquez, if I may interrupt you. So just going back to your model that you talked about, when the team is quote unquote off, how long are they off? You got the two teams.
So if they tested positive, so they
in general, like if you got a rotation system going and you're trying to keep one team unexposed. Is it like day by day they rotate, or is it week by week?
No, so that has been different between the different departments. So in some departments, they have done it week by week. So 1 week, one team, and the next week, the second team. But for example, in my department, what we are trying is to avoid each other. That's it. We have a strict, quite strict calendar, and you are supposed to do your task, but you cannot go and try to do other tasks that is not assigned to you, because in that case you will get in contact with your coworker, and that's what you have to avoid. Mm-hmm. So that has been different. And then what I was saying is we also had to deal with COVID patients and provide them with neurosurgical care. For example, and we will see it later, we had some COVID positive cases, and of course those patients have a neurosurgical postoperative healthcare or needs, so you have to attend those needs as well. Then regarding PCR testing for the patients, this was in the initial weeks, of course. The majority of the departments or the neurosurgeons were doing the testing when the patient were symptomatic or prior to surgery. I think this have changed, at least in my hospital. Now we are trying to test everybody or everything that moves. It's like if you are going to admit a patient, then you will need a negative test, to be able to admit the patient under your care. And if that patient is positive, we'll go to the COVID hospital. It's the same hospital, but the COVID wards. And of course, you will need to go and see the patient there, but you cannot admit the patient under you.
Right. With that second one, when you have prior to surgery, what's the timeline prior to surgery? I assume that's elective surgery, or is it emergency too? And what timeline is that?
Both. So for elective surgery is the day before. So okay, the patient is admitted the day before, and the test is run the day before. For urgent surgery, if it's something that it can wait, like for example, a chronic subdural, for example, that can wait 6 hours, for example. You can wait actually. So for that patient, you still have to have the test. And if it's like an epidural, for example, which cannot wait, of course. So probably in that case, we will need to treat it as a COVID positive patient. So in terms of oncology procedures, the specific impact on the oncology, what we know now from this survey is that almost 40% of neurosurgeons there was not an impact on neuro-oncology procedures. Another 40% said that that there was a partial impact, and for almost 20%, there was a total impact for neuro-oncology only. And an interesting thing as well, because there's a lot of literature about it, is the endoscopic endonasal approaches. We all know that these kind of approaches might represent a higher risk for infection of the surgeon. So the attitude towards these patients was that in 16% of the cases, they would do the approach, the endoscopic endonasal approach, regardless of COVID. Then the majority of them would do the approach if the patient tested negative, of course, and for a relative big portion of neurosurgeons, they would choose an alternative approach if possible.
Right. So from what you've heard from your colleagues, I don't know which category your hospital falls under, when they do proceed with the routine treatment of these cases, what are some potential precautions that they take? I've seen the whole gamut. Like I saw at UCSF, they had like, a little kind of like helmet around the patient to minimize aerosolization, because to recap for everybody, the virus is mostly in the upper airways, and when you do have a procedure through the nose and pharynx, you have a chance to aerosolize the virus particles for a very prolonged period. So I wonder if you've heard of any other interesting measures that people have taken to minimize the spread.
Not really, mainly the PPEs, and probably that's it. But in our case, we have been able to just avoid doing this type of procedures. We haven't had an apoplexy, for example, or a pituitary tumor with progressive visual decline, fortunately. So, but if we had one, we would need the test, of course. If it's tested negative, then we would do the procedure, probably with extra protective equipment, but nothing as the things you were saying.
Yeah, interesting anecdotal example. So in our guidelines that we published, we suggested that CSF leak from the base of the skull, cerebrospinal fluid leakage, this should be considered an emergency. If you're if you need to repair endoscopically, go ahead. I had an elderly patient who was repaired elsewhere, and she was leaking, and they were really obviously scared of coronavirus. So we managed with Diamox, and that kind of works. So it's interesting to see what other alternative ways we hear about and how they end up working. Dr. Lip.
Well, they're trying to, so from Cambridge, they just published some evidence, some pooled evidence of the way they're trying to avoid and some kind of different protocol of disinfection with iodopovidone diluted. And also they're trying to shield the surgical field with an adaptation of the shield for the microscope. So they basically cover everything, including the surgeon's hand with the shield, and you can see through it. So when you have to do some bony procedure, when you can aerosolize a lot, and as well for the endoscopic procedures. So they're trying to be fantastious and inventive on the topic. I think we need to be.
Yeah, I think that's the key thing that will emerge from the COVID era. There will be a lot of collateral damage from the impact of COVID, but also a lot of innovation, and we'll try to get to some of that. But Dr. Lipa, any thing to add from the European experience with endoscopic approaches, how they're doing differently in the different hospitals? Sorry, in Italy, not Europe.
Yeah, and in Italy, we are seeing that there's some like evidence have been published following the recommendation from China at the very beginning. So like it was I don't know, it was probably some kind of rumor which was not confirmed and in the end from Wuhan, that the first cases of spreading through endoscope was on neurosurgery and got 13 people infected. So this was apparently not true, but still it was ENT surgeons that were the first victims, and as well as odontologists and dentists. So the fact of aerosolization is it's so important for us neurosurgeons as much as for other professionals. So the importance for endoscopy has to go like as much as for ophthalmologists, because also tears can
Yes.
make those. Yeah. And for odontologists and tooth professionals. So
And a lot of like bone drilling as well. We don't.
yeah, exactly.
That.
Now we're avoiding that as much as we can.
Mm-hmm.
So we're using less and less drills, more and more actual craniotomies, even when we were not like you're used to do like you're drilling the bone and to do a more cosmetic procedure. But well, it's borehole. Definitely borehole now.
And jiggly saw.
And jigsaw, yeah. Which is even worse, possibly.
That's very traumatic. That's very traumatic.
For the surgeon.
Yes, exactly. All right, go ahead, Dr. Velasquez.
So, and then, of course, the question on what to do on COVID positive patients. So, a lot of almost half of the neurosurgeons said that they would individualize the decision, which is, well, is like a gray zone. And then, but it's important to highlight that almost more than 40% said that they would try to avoid doing a procedure in a COVID positive patient if possible. And then a minority said that yes, with personal protective equipment. Of course, these were the results of the first 2-3 weeks, maybe, right? So now through the pandemic, what happened? It's important to keep this in mind. Probably in Spain, as Dr. Luis Ley, the Vice President of the Neurosurgical Spanish Society, was saying in another webinar, that Spain was between the red and the yellow, probably. Not a full red, but just in between, especially Madrid and Barcelona, where the situation was critical at some point. So this is important because in this really nice paper published in the British Journal of Surgery that I'm sure we all know, it depends on depends on these what you can do as a surgical team or not. For example, in the red, you will limit procedures to life-saving surgery, for example. So it's important to know that in Spain, probably we were just in between these two curves. Of course, we were not in the green one, unfortunately. So what thing that we had to face was the surgical risk assessment in oncological patients. I mean, they have a tumor. If you don't do surgery on that tumor, that entails a risk. But if you do surgery and you admit the patient for surgery, then there's a risk of contagion from COVID, right? So, and that's something that we had to explain to the patient and to make sure that the patient understood, because it's a gray zone, right? For example, if the patient feels that surgery can wait, and the patient wants to avoid getting infected, then probably you have to explain a little bit with more detail to the patient what's the need of the surgery, and to try to decrease the risk. Of course, you should have to have a hospital for COVID patients. and a non-COVID hospital. What we have tried to do is specifically that, and you have to divide your hospital almost into two, trying not to get cross-contamination between patients. Then, of course, we work in a team. We are part of a team as neuro-oncological surgeons, and that hasn't changed during the pandemic. But of course, we were advised to avoid any meeting, any presential meeting. So we started with a teleconference for the MDT meetings in neuro-oncology. They have worked really, really well. In the past we didn't do this, and so this was our first experience. I know in the US and Canada, you are most familiar with teleconference for MDT meetings, but at least here in Spain, that's not the case. Of course, teamwork, and then priority setting, as the Spanish Neurosurgical Society mentioned. It was important to have a prioritization even beforehand the cases, because once you're facing a case, then or a patient, then it's difficult to make probably the right decision. But if you have a guideline that you have where you have prioritized the cases in advance, then probably it's going to be easier. And for this, and especially for the adjuvant treatment, like radiotherapy and chemotherapy, it has been really useful. For example, the recommendations from the literature and from a lot of different organizations. For example, this one. Pretty much we have tried to follow this when we can, of course, and we have to just individualize each case.
Right.
But for example, in patients, in older patients with poor KPS, then probably we are more, or we are leaning toward a supportive care rather than an aggressive care, for example. Or we are, in specific cases, we are considering shorter courses of radiation therapy as well, if possible, of course.
So just to clarify for our audience, Dr. Velasquez, if I may, so this is one example of some of the aggressive and most common brain tumors that we have. And this MGMT methylation status is one of the molecular tests that we do. It's a prognostic marker. It predicts whether you have a high chance of responding to chemotherapy, which is temozolomide. And if you're MGMT methylated, you have a better chance of responding. So in this case, the recommendation is standard therapy with necessary precautions. But if your prognosis is deemed to be poor, as Dr. Velasquez mentioned, we avoid temozolomide because in theory it can cause immune suppression, and we don't want to further increase the risk of people. And shorter course of radiation, so typically if you get 30 sessions of radiation, thinking here is to limit it a little bit more, just to limit the number of times you come into the hospital. And as he mentioned, people with poor performance and poor prognosis, just provide comfort care rather than have them have complications of COVID.
Yeah, exactly. And then the other question that we had to kind of answer during the pandemic was what happened to the COVID positive neuro-oncological patients. So I have two examples. First, the impact and outcome. Of course, we cannot answer that question right now, but it will be interesting to see the different studies after the pandemic to assess if the COVID positivity entails a different outcome in, for example, GVM patients, for example. Then post-operative care in COVID services, for example, these patients in the bottom who has a GVM by DH wild type, a young patient, and the GVM was resected in the initial weeks of the pandemic, but then it got infected, was admitted to a COVID ward, and then it had this swelling or this pseudomeningocele in the wound. So of course, the COVID doctors didn't know how to deal with this kind of things. So we had to actually provide the neurosurgical postoperative care to the patient while he was COVID positive, for example. Then, for example, and then for this patient, which is important, couldn't receive chemoradiation until 1 month, maybe, or even 5 weeks after the surgery, for example. And that's another important thing, because the patient was admitted as a COVID positive patient with COVID. And of course, there's a delayed rehab as well. For example, in this with this patient, the patient turned out to be positive like 1 or 2 weeks after the surgery. At this moment, the patient is an old patient who needed some rehab, and she hasn't been able to receive the full rehab she would have received in other situation, for example. So these are kind of the impact that COVID might have on the neuro-oncological cases.
Right. It's interesting on the flip side. So unlike the Canadian experience we had in America, discharge to rehab is quite easy and fast in most cases. I'm not talking about a positive patient, but we've had a challenge that some patients may not be keen on going to rehab because of the outbreaks at the long-term care facilities, the inpatient facilities. So that's perhaps another way that outcomes can be adversely affected as well.
Yeah, for sure. I think this will have, it has to have an impact on outcome. We will see in 1 year or two.
And Dr. Lip, I'm not sure if we'll talk about this, but you've been also talking about some of the collateral damage of COVID in the brain.
Yeah. This I didn't mention this specifically because I was expecting to jump into the discussion while Carlos was talking about this, because we are experiencing the same thing, and also rehab facilities have been repurposed and redeployed in as COVID non-intensive units. So we right now for a month and a half we couldn't send anybody to rehab.
Oh, wow.
So this was a problem in our not our region, but our region is divided into 3 main areas, and in our main areas, which was the most affected in the region, we couldn't have a formal rehab as previously as now has been reestablished. But this was a major concern in choosing to operate someone, even if it was a neurosurgical oncology case with clear indication. But then you have to expect either you keep the patient in the hospital for longer, thus increasing all the possible contamination and increasing the risk of infection in hospital, or you are simply know that you will have a delay in the rehab. It was a balance we had to consider for 2 or 3 patients mostly, not that much, but still, when you have to explain this to families and to the patients, it's, you see this huge meningoma with this huge edema, motor deficit, 55, 60 years old. What can you tell them? You will have some experience afterwards, and you probably will have some residual motor deficit, but we can't offer right now the rehab we would because of this COVID. So it goes into ethical at some point, but still, you have to save the patients from the major damage, which is the tumor itself, and then you start to establish an in-hospital physiotherapy program. Then they can continue home for a while, or they learn exercises. You involve more the family, and then off to rehab. Now they can, so it's better, easier.
Okay. Wow.
It sounds like they made COVID rehab
Yeah.
over there.
COVID rehab? No. It's not COVID rehab. Oh, yeah. This will be another topic, I think, not for neurosurgery, but in general. It's like when you get out of the ICU with COVID, you have a long way to go. So talking about neurosurgical oncology patients off to rehab, now the facilities are open again. Before they were repurposed for COVID patients, so you couldn't send people off. But now, about COVID patients off to rehab, we never had. We were lucky enough not to have any patients with COVID undergoing a neurosurgical procedure. So we were lucky. Otherwise, I don't know. We had protocols already in place for that, but we didn't. We never had, the need to actually put them in place.
Thankfully, yeah.
But, yeah, thankfully.
So in this, specifically in these situations, it has been really helpful, the different guidelines and recommendations from different organizations. And I just wanted to highlight this. For example, guidelines from IANO, from IANS, from the Neurosurgical Spanish Society in my case, and of course from SNO. Like these kind of papers from Dr. Zade, and I think these all these guidelines and recommendations have been really helpful through this time. Dr. Mansour, you wanted to comment on this?
Yeah, and recognizing that this is a constantly evolving situation, we got together with some colleagues with the recognition that most brain tumor patients cannot wait to have their surgery postponed. But there is no precedent. So we thought trying to put forth some guidelines would be helpful. So obviously this is region by region and not set in stone. And as we learn more, it will change. But if you could go to the next slide, please. Yeah, so in terms of the timing, we have two columns here. In terms of emergent procedures, these are the ones that the patient is having impending herniation. This is life-threatening if you don't do something immediately. And as you mentioned, we assume the patient is COVID positive. We do the testing. We use every enhanced form of PPE, as you can see in the corner picture over there. And the patient is kept on quarantine and isolation until the results of the test come back positive. Then there's, as you mentioned, some of the GBM cases where you suspect it will be a high-grade glioma and you cannot wait too long. You try to temporize as much as possible with steroids and anti-seizure medications. If the testing is widely available, we proceed with surgery. We test them, proceed with surgery, and again, quarantine them until the results come back negative. And if testing is not available, then we take every precautions. And the other key thing is, I'd like to know your input, guys, is a minimum number of required staff. And I'll get more to that in the next slide. And then we have several recommendations for semi-urgent cases. So we already talked about endoscopic cases being at high risk of aerosolizing the virus particles. And I find that it's become more institutional to institutional. No real firm guidelines have been established. So we try to consider transcranial if we need it. We try to postpone it as much as possible unless it's an emergency. Dr. Velasquez, you do a lot of awake craniotomy. There is a concern that, as the laryngeal mass goes in and out, you may be spreading the virus. So I'm curious to know if that has impacted your approach to that. Right now, we would consider a sleep mapping as much as possible with EMG. And, if it's in a tricky spot and we really would like to do it awake, for now, we try to do a biopsy only to try to get diagnosis and then plan to come back for a more full-fledged approach. What has been your practice with the awake cases?
So we haven't done any awake case during the pandemic. We have tried to avoid them, trying to do what you just said. There's a specific consideration. We usually do awake mapping for language, of course, and these patients are usually low-grade glioma patients. And probably in these patients, you can wait until you have the best conditions possible in terms of the pandemic. That's one thing. And then whenever we had a lesion really close to the motor area, pyramidal tract, then we always did a sleep mapping, motor mapping only. Of course, well, you have to keep in mind something, that we wouldn't do a procedure if it's not COVID negative, for example. So you already know that the patient has a negative PCR. So, but even in that case, we would try to avoid the awake craniotomy, just because what you said, that we usually use an awake asleep procedure. So we have to put in and take out the laryngeal mask at least twice during the surgery or more. And of course, that entails a risk, especially for the anesthesiologist. So we have been trying to avoid that.
Mm-hmm. Dr. Lipa?
So we didn't do any awake during the pandemic as well. The concern happened like once, but we were able to postpone. It was low grade. It was really low grade glioma, so we did all the advanced neuroimaging to confirm it was a low grade, and as much as possible, like just to go over after the quarantine, after the lockdown, because even though at the beginning, you know, it's maybe like seizing patients and you want to give the best care you can, you still have to consider the whole picture. And you don't know how it's going, where it's going, and you know how it's at the very beginning, when we were in the middle of it, it was like day by day, you just woke up and say, what's happening today? What's gonna happen today? How is gonna rise up the cases, and how will be the numbers? And it was an immensely stressful environment for everybody, but for healthcare practitioners, which we had to provide some kind of security to patients still, and we couldn't. And we have a young patient with a low-grade glioma who's seizing and cannot drive anymore. Not they couldn't anyway, because they were in lockdown, but anyway, couldn't drive anymore. They were just dropping everything in the house, and maybe kids were, kids were scared. And so there were many concerns. And in this kind of context, all you have to do is to try to keep them as reassured as you can, and just go over. Now we know that the pandemic has some kind of, the waves can be tamed somehow if we all do something to do this, if you all manage together. So right now we're like bracing up all our forces to gather all this kind of patients, now that we have full PPI and we have full testing available, and beds and ICU facilities are free. So now we can go and restart with them, even though they're kind of elective, they're still oncology, so we will be allowed to do them.
And that's a very interesting challenge you bring up, the low-grade glioma patient who is at risk of seizures because the mass is still there and they're still at home with the social isolation. You don't have necessarily family to come to watch over them. How do you keep track? And I guess telemedicine option be.
Yeah, telemedicine, yes. Just phone calls and video calls, and it happens just with I think 2 or 3 patients. It worked. So, you know, when you're in the middle of it, you just try to get day by day, because you have to just get them through with you until you can do something more. And the appropriate, you don't want to go below your standards. This is the other thing. Like, also the biopsy now and treat after, it's still 2 interventions. So here in Italy, we could never, ever try to propose that, because if anything, if the patient doesn't like the scar of the biopsy, they will sue the hell out of you. So the management will not allow you to do something like this because it's below the standard.
Interesting. Okay. Next slide, please.
So just a few comments on the post-pandemic era, what to expect. First of all, this is a letter from a neurosurgeon in Spain and another one in Italy, which shows the decrease in the number of cases they receive in their practice, right? So where are these cases? So these cases, I think we all agree, these cases are at home waiting for the pandemic to end. So probably a case like this will become a case like this when it shows up in the emergency room. For this one, probably, I'm just making this up, but for this one, you could do radiosurgery, but for this one, you will have to do surgery, for example. So this is an interesting question that we will see the answer in the next weeks and months, and I think Dr. Lipa will comment as well.
Yeah.
And then,
yes.
What to expect? I mean, we have to expect a second wave. I think the question is how big it's going to be. That's one. And the second question is how are we going to prepare for this one? Because it's not going. It shouldn't be as the initial impact that COVID had on the neurosurgical departments at the first time. Now we know COVID, we know how it is, we know how a pandemic behaves, so we should be more prepared maybe, and I hope we will. Then, of course, this is, and I think I find this quite interesting, the Spanish paradigm shift to telemedicine, because here in Spain, we like to talk to people in person. You know, it's and even for the doctor-patient relationship, that's what they expect, and that's what you expect. You want to see, well, the expressions, and when you are just explaining about the surgery and so on. But well, this probably will have to change. So we are moving to a telemedicine paradigm with a telehealth clinic, teleconference. As I was mentioning before, and probably we will learn how to improve the online healthcare patient communication, and I think that's gonna play a significant role when we face the second wave of the pandemic. These were some of your ideas as well, right, Dr. Mansouri?
Yeah. If we could click through that, please. So it's a little bit out of sequence, but we've tried to transition to telemedicine as well, and it has had its own glitches. So in the United States, we're opening up our outpatient clinics, but we've taken steps to mitigate risk as much as possible. So we've completely reorganized our clinic and waiting room structure. So the chairs are kept at least 6 feet apart. There's a minimal time in the registration area. So when you come in, you register, you go right into the clinical exam area. Obviously, surface cleaning and hand hygiene and personal protective equipment. And before they come to the office, we have these screening questionnaires. And if there's any suggestion that they may be positive, that appointment is canceled and directed to a outside tent that we have for testing patients. And as we all mentioned, canceling or delaying non-urgent appointments. But the telemedicine transition has not been as smooth as one would hope. You know, not everyone is keen on the video. They don't have the capabilities. They want to do telephone if that's an option, and that's even more problematic. And it's just some of the patients that I thought were surgical based on telemedicine, that you bring them in for an exam before you even decide to do anything next, and they're clearly not surgical. So the decision making becomes much more challenging. So I think it can be a good tool for follow-up imaging if you want to report the results of 3 months MRI, or if you want to do a quick screen to see who should come in or not. But I just have a feeling it will not be a replacement, but more of a supplementary tool. And it will be interesting how things look in the next few days and months, as you mentioned. I'm very curious to hear about the hub and spoke model that we keep hearing, as there's more increased calls about that. So even in Canada, for example, we hear these headlines about cancer and cardiac surgeries being delayed. And there's thought about, as we try to go back, having these major hospitals do the cancer surgery and they're kept COVID negative, and all the other peripheral hospitals manage the COVID patients. I'm curious to see what's going on in Italy and Spain.
For Italy, this was started in Lombardy, because Lombardy is the most populated region in Italy, and they needed somehow to establish a firm COVID-free hospital. So they were quite, for neurosurgery, they were quite lucky, also for other disciplines, because they have actually the best organization of health system in Italy. So they were quite lucky because they had some hospitals which have no ED and which already did mainly neurosurgical oncology, or anyway oncology. So they were already prepared to gather cases, lots of cases. So basically what they did, like this is gonna appear in one slide later, but they simply stopped doing all cancer surgery elsewhere in the region. So one single hospital became the hub for neurosurgical care in terms of oncology for 10 million people. And since it's a lot, spoke equipes, so the equipes from teams from different hospitals were going to the hub and perform surgery there. So because the equipe of a single hospital cannot cope with all of them. So I see this patient in my hospital, I cannot operate on this patient in my hospital, I will refer this to the hub, I will get tested, I will go there and I will do the operation.
Mm-hmm. That kind of a model, I imagine, would be difficult to implement in the United States, where there's different health networks and insurances, et cetera.
Exactly. This is the other thing. So we are talking about free healthcare, universal healthcare in Italy. So we're talking about something that we don't have to think about financial thing. Insurance. I couldn't even imagine to have to call someone myself to bill a patient. It's something that goes really, it's beyond my mind. So I just don't think about it. So they just decided to redeploy surgeons to COVID, surgeons to non-COVID, and to work together like this. But this kind of hub and spoke model worked very well also for other disciplines, not just neurosurgery. At the same time, this couldn't work in Tuscany. So we don't have this kind of facility. We don't have a hub. We have a hub for trauma, but we can't have hubs, just one hub for neurosurgical oncology. This can't happen. So it's Lombardy, of course. I don't know elsewhere in Italy, but elsewhere in Italy, I might say that the incidence of coronavirus was way, way milder, so that they wouldn't need it.
Mm-hmm.
So we have a prevalence north and far more than south Italy, like in Spain.
Yeah. Like, for example, the thing is, I think they couldn't do this in Madrid or neither in Barcelona because the pandemic was so bad that they just stopped. They just stopped doing like most of the neurosurgical cases, only the emergency ones. So, but probably for the next waves, I think this is something that of course we can explore. And another thing is the role of outpatient neuro-oncological surgery during pandemic outbreaks. So we have a program of outpatient neuro-oncology surgery, like the one Dr. Bernstein has in Toronto. Well, not like that one, but we're trying to grow in that sense. But unfortunately, we were not prepared for, in our program to do outpatient oncological surgery through the pandemic. So we had to stop. And actually, we had good cases who fulfill the criteria to be treated as outpatient as an outpatient procedure, but because we didn't have like the planning and the logistics, the hospital management didn't let us do it. But for the next waves, I think this is going to be important, because in this way you can decrease the length of admission, for example, of course, and the risk for that specific patient. So I think for the next waves, we will be more prepared to do these kind of tumors as an outpatient procedures, and of course spine and so on. And then just a brief comment. Probably, I don't know if it's the right time to think about research in oncology, but at some point, I think we will face that a lot of resources have gone to some other type of research, for example, and then we will actually realize that to stop in our labs, for example, the lab where I work has been closed during this time because it's not something that it's urgent, right? So this 2-month stop, I think, will have an impact later. Mm-hmm. And then just to briefly conclude the part from Spain. The COVID pandemic has significantly impacted the neurosurgical care for oncology patients in Spain. Nevertheless, I think we have managed to try to give some answers to these patients. Then the neurosurgical departments and neuro-oncology MDTs, we need to adapt to different scenarios during the pandemic. The priority setting of cases and the team organization has been 2 key factors that have allowed us to go through the pandemic. And then the paradigm shift that I was talking about, that we will have to increase the telemedicine part in our daily practice.
Yeah, just a note about the research. Sorry, before Dr. Lipa, you go ahead. You mentioned we're not sure if it's the right time to be thinking about it, but I would argue that especially for more malignant brain tumors like GBMs, research and particularly clinical trials are an integral part of treatment. It is experimental, but because we are so limited in our management options available, we are setting back future treatment. And as you said, a lot of funding organizations are either out of money and they're not funding non-COVID research, or foundations which are dependent on donations are not able to fund the money. So that's the one downside, but it would also be interesting to see as we look into the future with like some of the registry-based studies, what epidemiological trends and changes we see as COVID happened when it comes to brain tumor care. So I think perhaps it's an opportunity for better learning as well.
Yeah, I agree. I totally agree. Yeah. So Dr. Lipa, I think you can go ahead, please.
Yeah, so what you said just up until now, it's absolutely valid for Italy as well. So we had a similar timeline, a similar kind of management of this huge pandemic, similar kind of numbers, sadly, and we were similarly hit with a similar gradient from north-south Italy. So if you go to the next slide. So basically the outline of my brief points are, it's pretty much the same as yours, but what we saw is a little bit, we were kind of earlier, we were kind of, everything happened before Spain, a little bit before Spain. What we felt when it started in Italy is that we weren't believed. So we felt in Europe and in the world that nobody was believing us. We were trying to warn people and they were not believing us. And this was the most disheartening thing that happened in the very beginning. So they were like, not paying attention. And it was like, how can you not pay attention when I'm lining up coffins? These are the numbers right now. So this was taken yesterday night and our actually positive cases, and our deaths are over the 30,000. And so we have more than 200,000 patients with coronavirus. So you see the gradient is similar to Spain. So there's northern Italy, is Lombardy and Piedmont and Veneto as well, and Emilia, which is kind of between. So if you go to the next slide, you see where Tuscany, no, not yet, but Tuscany is kind of the middle of Italy. So it all started in the end of February. So Tuscany, exactly, thank you. So in Lombardy, the first cases were the very first case was spotted in the 21st of February. It's on the next slide. And from that day, the statistics are taken yesterday, both for Lombardy and for the US. So the Lombardy has a population which is roughly a little bit more than New York. New York has the double of cases, the same deaths up till now. And our population density in Lombardy is quite the same, maybe some little bit less than New York. I don't know about the swabs and testing in New York. I don't know how many were performed. I don't know if it's even possible to count, actually. But we're seeing that the governors are trying to do some really good work. But what happened in Lombardy, everything was so sudden. You will see lots of reports in literature now. So this is ACTA, but then there is JNS as well. So all our colleagues from Lombardy went above and beyond to cope with this huge wave of cases, which was completely unexpected. And it hit hard, and they couldn't cope. So they had to scale up with the ICU. They had to scale up in a big time. So it was like 3-time-fold increase of ICU beds. It happened in 10 days. So during the first case in Lombardy and the first case in my department and in my region, which was the 3rd of March, this is the next slide. So we have some kind of span. So what happened in Lombardy is that they were able in a fortnight to put in place a hub for neuro-oncology, which was the Best Institute, which was already, as I was telling you before, emergency department was already bound to neuro-oncology. So it gathered all the cases for Lombardy, and it kept from different spokes hospitals that went there to operate on their cases. But all the other hospitals were COVID, just COVID everywhere. And we don't have from Tuscany that perception. We were talking with them daily. My chief of department right now is from Bergamo, so he was very concerned. He was talking with colleagues like on a daily basis, and we were trying to get the picture as much as we could from afar. And when the first case happened in Tuscany, which was the 3rd of March, you see the next slide. So Tuscany had, we are on the coast in my department. So the biggest one is Florence. So the very first case was the 3rd of March. And by that day, Lombardy had an experience over 1,500 cases. So they were already experienced in treatments. So they bought us time. They gave us their experience so that we could contain it. So we had time. In the meanwhile, lockdown was put in place, and our population density in Tuscany is quite reduced in comparison of Lombardy. So it's easier to contain a disease when you're in lockdown and when already you know how they're dealing with it. So we scale up things and we prepared as much as possible. And no matter what, it hit, and it hit hard anyway. So we had 1,000 of deaths, which is a lot, but not as much as in Lombardy. Lots of cases, mostly on the coast and mostly in the northern part of Tuscany, as you see. Like the northern part of Tuscany behaved a little bit as northern Italy, while the southern part of Tuscany behaved very, very well, like the southern part of Italy. And what happened for us is that we benefited from their experience, from Lombardy experience, and we tried as a nation to warn Europe. And we were sharing this kind of sensation with our other professionals. We are not the Middle East, so even I remember, I distinctly can recall talking with colleagues from Sweden, from Rwanda, from UK, saying this brace up because this is nasty. They'll say, oh yes, I don't know how it's your situation with your virus. Okay, fine. And then Spain started shortly after, and it was exactly the same. So I think that after Spain started, I don't know, somehow the situation was clearer for everybody. So they kind of were alerted, more alerted than before. So you go on the next slide. What happened, even though things went differently, we halted completely elective surgery and outpatient clinics. So we had like 10 people per day via telemedicine, and just complicated wounds, surgical wounds, or just things that you have to see. Otherwise, no way to enter the hospital, no way to get out of house. And we were still following some kind of governmental leading. So it was not guidelines, it was experience, and it was governmental. So governmental leading is not necessarily a scientific approach, or when it's a new virus, science is some kind of, you have to adapt with what you have, with the experience you have. And the lockdown allowed us to have less major trauma, kind of less presentation of ICU requiring things, but at the same time, we started to see less myocardial infarction, less stroke. And after 2 months, we can say that many more died for myocardial infarctions and many more died for stroke. Still, we had minor head trauma. So people were still cleaning their roofs and their windows, and they fell anyway. So we still continue to perform surgical procedure on trauma, quite a few. And luckily, because we didn't have testing at the very beginning or appropriate PPE, we weren't equipped. We're full PPI and we're N95. We didn't have it. Simply, we just have it for the ICU and for the general outpatients and inpatients, and for the ward, you simply had the simple surgical mask, and that was it when you had it. So luckily, like industry, and there was a quest for PPI, and it was had a kind of quick. So we felt much more safer in a matter of a week or so. Each center in Tuscany was able to continue to perform neurosurgical care in terms of oncology. Still, we rely on the ENO, SNO, and ENS guidelines for all the parts of MDTs and all the parts of follow-up and temozolomide avoidance if we can. So still, you do perform surgery, but then you have to adapt as much as you can care, or postpone care, like oncological care. So the continuous update, I don't know how it went for your experience. The continuous update of protocols was kind of confusing for many at the very beginning. Like the things you are allowed to do this morning, you're not anymore allowed to do this afternoon. So the processes were changing, the paths were changing, the COVID area were growing. So we're like, okay, now these wings go to the COVID, now these wings again. So you add up places in the hospital that goes into the COVID area. And this has as an impact on healthcare providers.
It's interesting how when I hear you, it's like you're describing my hospital during the last 2 months. It's the same, and especially,
I understand.
especially the policy, the changes in policies, which occurred in every level, like from the government to your department. Like my chief was like trying to adapt to the new situation, so he was changing the protocols. It's interesting how the same happened here.
Yeah, I guess that was it was very close in time and also close in numbers. That the experience was really close, our Spanish and Italian experience. So also the teamwork and the management that you were describing, like the taking turns and the small teams and the avoidance of too many people at the same time, like to try to cover 12 hours straight rather than 6 hours and 6 hours, so just to expose less number of surgeons to the ED, to the possible contagion. So this was actually the hardest part, coping with all the uncertainties. As a healthcare practitioner, you're used to provide certainties to your patients, or at least to provide science as much as you can, some answers that you can rely on your source. There was no source in this moment, so you could just say I don't know. And when you say I don't know, I as a surgeon it's always a mixed feelings. You're kind of it's emotional, and you feel bad for the patient. Even if you are being honest, but in this case, it was terrible. I felt terrible, not able to shake hands, not able to make myself think like reassuring or smiling, or with the mask. Also, the interaction were different. I felt that all this in neurosurgical oncology has a huge impact on the patient care, and this I think we all felt somehow this part of the impact. I don't know for you, how was your experience about the way patients perceived you in this moment, like more distanced? I don't know, the distancing was also in the perceived care.
For me, I think the patient, all the patients were quite supportive. When you call them at home, they didn't really care that you couldn't provide the healthcare they need in that time. They were saying like, you stay there and be safe, and try to stay safe, and we appreciate what you're doing. That is something I think we will have to see what's going to happen now, because they are still needing healthcare and their surgical care, and now probably the pandemic is not is not as important as it was 2 weeks ago. So for them, their needs will get priority now, and probably you will have long waiting list for OR, for clinics, and it's going to be difficult to deliver now. That's another.
I guess we have a couple more minutes maybe, and let's just
yeah, of course, just keep it. Okay, so collateral damages that were that basically what we saw was not that those healthcare providers that were in hospital were dealing with infections, but mostly people with pre-hospital care, emergency care, GPs were high rate of infections. So collateral damages is like we lost 160 fellow colleagues in Italy. And the people were feeling unsafe coming to the hospital or asking for GPs or looking for specialist care. So this was something that happened in 1 month ago, mostly, 1 month ago. So a patient came in for epileptic seizures, and this was a cerebral abscess from an untreated tooth decay that evolved in 10 days. So it was delayed treatment, delayed prevention, and this is an important thing to consider when you have to take care of this kind of patients. Next. So research, the time is now. We have to be, we are overwhelmed, our systems were overwhelmed, but we have now all the samples and the cases and the patients to study. So these two studies are sponsored by the University of Birmingham, and they're trying to discover how the outcome will be in surgery during COVID period and in cancer surgery during COVID period. So just start to explore this flow chart and see if you can apply to this. And next. So there are just few messages to, so we 3D printed some PPI, like some face shield, some mask holder, and we saw lots of research going on, a lot of fellow colleagues publishing lots about COVID. But the point is that we need to be ready for the second wave, as Dr. Vasquez was saying. We need to be able to scale up testing again, ICUs again, reorganizing telemedicine, and education at population level and healthcare practitioner level. So we also provided some task shifting and sharing to be prepared and to be able to provide care into COVID department, ICU department, and to be ready to be really helpful. And I really hope that this kind of continued medical education on a virtual basis continues, because it's very, very helpful to a lot of people. Thank you.
Thank you. That was fantastic. Thank you very much. It was very insightful. And I've definitely learned a lot about what to expect in the next few weeks, perhaps, as we
hope not. We really hope
to report
you're
back
containing
to
it.
How things have gone. I'll let you know.
We hope not.
Well, thank you very much. Have a great evening for you in Europe, and whoever has stayed, thank you very much for attending. Have a great day. And,
thank you to you.
Thank you, Aaron.
Thanks.